Uh, I'm Khadija Humayun, uh, working at Aga Khan University as a pediatric endocrinologist. Uh, it's a relatively young specialty in Pakistan, but definitely involves too many things going on. And when we were thinking what to do for this discussion, what talks, so the obesity epidemic in children is one thing which is facing us with all its might. There was a time when we used to talk, when we used to say कि ये developed countries की बात है, it's no longer that. We are equally involved. So without much ado, I would be initiating the session, and it's indeed my honor and privilege to call upon as chair, Madam Zeenat Ihsani. मैम का तारुफ हम सब उनको जानते हैं, वो किसी तारुफ की मोहताज नहीं, उस्तादों की उस्ताद हैं, ex-director of NICH, professor of pediatrics, trained in UK and Pakistan. मेरे नज़दीक मैडम का मकाम I give part and parcel of my being a pediatrician to her. She was the one who encouraged me, guided me, and that was the journey which started with her support. So thank you for being with us. Thank you. And then I would call upon Dr. Mumtaz Lakhani to grace the session as being co-chair with Dr. Zeenat Ihsani. Dr. Lakhani bhi kisi तारुफ की मोहताज नहीं है, a neonatologist and pediatrician. She has served PPA in various capacities. Again, she is my teacher, and I learned neonatology when I was doing residency from her. So thank you for being with us. She has a lot of work involving not only neonatology, but also multiple aspects of pediatrics. And then finally, I would call upon Professor Khemchand Morani to please co-chair the session. Professor Khemchand is, after Professor Afroz Ramran, the pioneers of pediatric nephrology in Karachi. He was leading the NICH nephrology, and now he is working at the Kidney Center and has also been one of the initiators of Pediatric Nephrology Fellowship by CPSP. So before starting the session, we thought we'll give you short intros, short glimpses of the problems that we are facing in obesity, in pediatric obesity. And then we will be open for a panel discussion and question answer session. But before starting, I've been assigned the task as moderator to announce that there is a Young Researcher Award for the presenters of the young lot who are going to present their research papers. And that award not only involves a shield, but also a cash award of rupees 10,000. So all the best to the presenters. We have 3 papers selected for oral presentations. And Ma'am Zeenat, Dr. Lakhani and Dr. Khemchand, ये जिम्मेदारी आपके सर है कि आपने फैसला करना है who is the best, and once you decide on that, we'll announce it towards the end of the session. I think end of session पे तो बताऊंगी, लेकिन अभी आपको बता देती हूँ कि end of session will go to the tea, which is at the pool side, And after tea, the plenary session would start at 11 in the same hall. So you will be coming back to the same session. Yes, there are poster presentations which would be judged, and again the awards given to the presenters. So let's start the session. And it feels, although Doctor, I wouldn't call him a chair or a co-chair, but as Babae Pediatric Endocrinology with Professor Taid Bhatt, who's not here, Dr. Jamal, it's befitting for Dr. Jamal to be sitting at this stage. So thank you. Presently, he's the director of Sindh Institute of Child Health and Neonatology, ex-director of NICH, and his efforts are a major contributor to coming alive of pediatric endocrinology in Pakistan. इरादा तो ये था कि मैं सिर्फ मॉडरेट करूंगी और बाकी काम दूसरे लोग करेंगे, लेकिन कुछ मजबूरियां, यहाँ तो ताख़ीर वाली बात नहीं है, वरना मैं अल्लामा इकबाल का शेर पढ़ देती कि कुछ हुई ताख़ीर तो कुछ बाइस ताख़ीर भी था। हमारे कुछ साथी जिन्होंने हमें ज्वाइन करना था, चंद मजबूरियों की वजह से, जो बहुत जायज़ मजबूरियां थी, हमारे साथ आ नहीं सके। इसलिए हाँ, ये जिम्मेदारी मेरे सर आई है कि मैं आपको पहले इस मौजू के बारे में थोड़ा सा बताऊं, जो मैं कह रही थी कि ओबेसिटी, हम क्यों परेशान हैं। आप पीडियाट्रिशियंस यहाँ पर बैठे हैं, 1975 से अब तक ट्रिपल हो गई है दुनिया में, एंड दिस इज नॉट पीडियाट्रिक्स, दिस इज होल ह्यूमैनिटी। 2016 में WHO ने फैक्ट्स और फिगर्स जब देखे तो 1.9 बिलियन एडल्ट्स who were 18 years or old were obese, और उसके बाद इनमें से अक्सरियत उन मुल्कों में, उन जगहों पर रहती है जो लो मिडिल इनकम कंट्रीज कहलाते हैं। 39 million children below 5 years were overweight or obese in 2020, just imagine। और 2020 के बाद, सारा कोविड की एपिडेमिक के बाद, ये नंबर जब WHO फैक्ट्स और फिगर्स रिलीज करेगा तो पता चलेगा कि ये कितना ऊपर चला गया। So the reason why we are doing it is obesity is something which is preventable, although there is some genetic basis to obesity which Dr. Jamal would cover, but we all know that it is preventable. आप ये देखें कि अफ्रीका में नंबर ऑफ ओवरवेट चिल्ड्रन लेस देन 5 जो हैं वो 50% बढ़ गए 2000 के बाद से, यानी 2 दहाइयों में जो परसेंटेज इंक्रीज है वो मोर देन 50% है। और उसके बाद वो बच्चे जो ओवरवेट हैं 5 साल से कम के, उनका 50% एशिया में रहता है। दैट्स अलार्मिंग। और हम भी एशिया में ही रहते हैं, इसका मतलब है हमारी जिम्मेदारी है कि इन बच्चों के लिए हम कुछ करें। एक तरीके से वो 2 धारी तलवार, जिसे डबल बर्डन ऑफ मैल न्यूट्रिशन कहते हैं, एक तरफ हम फेस कर रहे हैं, हमारा बच्चा स्टंटेड है, अंडर नरिश्ड है, और दूसरी तरफ यही बच्चे इन्हीं में से ओबीस हैं, ओवरवेट हैं। सो व्हाट कैन वी डू अबाउट दैट? WHO के स्टैटिस्टिक्स जो 2016 के हमारे पास हैं, उसके हिसाब से 20-21% ऑफ एडल्ट पॉपुलेशन ओवरवेट थी और पाकिस्तान की आबादी का 43% बच्चे। और डॉक्टर जमाल जो पीपीए के इनॉग्रल में बता रहे थे कि हमारा बर्थ रेट इतना बढ़ गया है और इतनी आबादी बढ़ गई है, उसके हिसाब से बच्चे और बढ़ गए होंगे 43% से। एंड इन बच्चों में 15 to 20% are overweight or obese. Let's see that होता क्या है। एक बात कही जाती है कि वो बच्चे जो ओवरवेट हैं, ओबीस हैं अपनी बचपन में, they are going to be obese adults. And obese adults का मतलब है कि they'll have all those complications and problems that obesity leads them to. बच्चों में ओबेसिटी की डेफिनेशन को एक दफ़ा देख लेते हैं, फिर आगे बढ़ते हैं। 5 साल से ऊपर और टीन एज में BMI ranges above a normal weight have different label, a risk of overweight or overweight. Risk of overweight की बात होती है at or above the 85th centile, and overweight होता है above the 95th centile. BMI के charts WHO के available हैं, freely available है online, and you can use them to plot. Less than 5 में बात होती है 2 standard deviations above the WHO growth standard median. और obesity would be weight for height which is greater than 3 standard deviations. So I'll quickly run through the WHO charts that I referred to are available for all age groups, for boys and girls differently, and you can easily plot them. So उम्मीद ये है कि आपकी क्लिनिक में जब बच्चा आ रहा है तो उसका वज़न होगा, कद होगा, काइंडली उनको प्लॉट करें, उनको देखें कि वो कहाँ जा रहे हैं, और वालिदैन से डायरेक्ट कांटेक्ट आपका है। कहा जाता है कि माँ बाप के पास पैसे पूरे ना हों अपने इलाज के, लेकिन बच्चे का इलाज वो ज़रूर कराते हैं, और पीडियाट्रिशियंस ये वाहिद बेहतरीन ज़रिया हैं गाइडेंस का, डायरेक्शंस का, कि इस ओबेसिटी को हम किस तरीके से कंट्रोल कर सकते हैं। होता क्या है, इसको फेजेस में डिवाइड किया गया है। स्टडी इंक्रीज इन चाइल्डहुड ओबेसिटी, उसके बाद फिर सीरियस ओबेसिटी रिलेटेड कोमॉर्बिडिटीज, इसके ऊपर मोहसिना इज गोइंग टू टेल अस अ लॉट ऑफ थिंग्स, व्हाट आर द कॉन्सिक्वेंसेस, एंड देन medical complications will ultimately lead to life-threatening disease. ये बच्चे हमारी अगली नस्ल, हमें नहीं पता उनकी लाइफ एक्सपेक्टेंसी क्या होगी अगर वो बचपन ही से ओवरवेट और ओबेस हैं। और फाइनली फिर ट्रांसजेनरेशनल ट्रांसमिशन शुरू हो जाता है। व्हाट डू वी मीन बाय दैट? एक ओवरवेट माँ, हो सकता है प्री डायबिटीज़ हो सकता है उसको जेस्टेशनल डायबिटीज़ हो जाए, and as a result of which the baby that is going to be born is going to be large for gestational age, or maybe actually SGA. Both of them are precursors for ultimate overweight and obesity in childhood and then in adult. और उसके बाद अगर इंटरवीन ना करें इन बच्चों के लाइफस्टाइल में, इनकी ज़िंदगी में, तो 50% are going to be obese adults. And then we all know the problems, hypertension, cardiac morbidities, risk of MIs, risk of strokes, risk of diabetes, joint issues, liver issues, and kidney problems. These are the ones that we see day in. अभी तो बच्चे बचपन से वो अपने जोड़ों गोड़ों गिट्टों की बात करते हैं कि दुखने लगे, चला फिरा नहीं जाता, काउच पोटैटो बन के बैठ गए। This figure very clearly depicts the problems that can happen. बात सिर्फ बीमारी पे ख़त्म नहीं हो जाती. जब बच्चा बीमार होगा तो फाइनेंशियल बर्डन तो पड़ेगा, माँ बाप पे भी पड़ेगा और सरकार पे भी पड़ेगा. So PPA is one body which is looking after the health of all children all over Pakistan. So this is the time when we think about it, how and when can we start taking care of this epidemic, prevent it from reaching in further increased gross proportions, and let's hope that our next generation is going to be better. क्या वजूहात हैं? मेरा ख्याल है हम सब अपनी उंगलियों पे गिनना शुरू करें तो तमाम उंगलियों के पोर भर जाएंगे. टेलीविज़न टाइम, खाना. कल in a workshop my colleague Salman was saying a very nice thing. खाने की इज्जत ख़त्म हो गई है. एक ज़माना था कि खाना खाने बैठते थे तो कुछ और नहीं होता था. Now the parents are engrossed in their phones. The child may have his or her own tablet in front of them, or the television is on, movie लगी हुई है. उस दौरान क्या खाया, कैसे खाया, पता ही नहीं होता. हरकत में बरकत थी, माहौल ऐसा हो गया, बच्चे बाहर नहीं जाते, घरों में भी नहीं चलते, वो सारा वक्त बैठे हुए टेलीविज़न के आगे. डेफिनेटली कुछ जेनेटिक फैक्टर्स हैं, ऐसे हैं जो हम बीइंग कॉन्सैंग्विनिटी इतनी हाई है कि वो फैक्टर्स हमारे यहाँ काम करते होंगे. डॉक्टर जमाल को ज़हमत दूंगी कि उसके बारे में बात करें, लेकिन बाकी चीज़ें हम सबको पता हैं. द लाइफस्टाइल इज़ द मेजर प्रॉब्लम. द कल्चर ऑफ सुपरमार्केट्स. आप खाना लेने जाते थे, पहले मोहल्ले की कोने की दुकान से एक पाव चने की दाल लेनी है तो ले आते थे. अब जब चने की दाल लेने हम लोग सुपर स्टोर जाते हैं तो चने की दाल के अलावा कोल्ड ड्रिंक्स का एक बड़ा पैक, केचप की एक बाल्टी और बहुत बिस्किट और बहुत सारी चीज़ें हमारी ट्रॉली की वो होती हैं. उसका फाइनेंशियल बर्डन जो है सो है. उन सब के साथ these are the causative factors that are contributing. The stress has gone up. वक्त नहीं है, खाना भाग दौड़ में खाया जा रहा है. वो लेप्टिन जो रिलीज होनी है धीरे धीरे चबा चबा के खाने से वो बेचारी अंदर ही कहीं धरी रह जाती है. So these are all the contributors that you all know very well. This is the time that I want you to start thinking how to take care of them. That is all that I had to say. And now I would request Professor Mohsena Ibrahim, my colleague, my friend. She is the professor of pediatrics and pediatric endocrinology at NICH. Her MBBS is from Lahore, and then Karachi had the honor to train her in pediatrics and pediatric endocrinology. She's one of the few initial supervisors of pediatric endocrinology, is very actively involved, not only training her juniors, but also in publishing. So over to you, Mohsena. Thank you.
Assalamu alaikum, everyone, and thank you, Dr. Khadija, for such a nice for my introduction. I owe also my presence at NICH to Madam Zeenat. I entered in her office without any sifarish. तो मैंने मैडम से कहा मुझे आना है. मैडम ने कहा yes you can come. मैंने part 1 किया है Peads में, and I want to do pediatrics. So I owe my presence in Karachi and at NICH to Madam Zeenat also. Thank you, Madam. Now the topic which has been given to me is the consequences of obesity, metabolic syndrome and pre-diabetes. So bear with me, there are little numbers and figures, लेकिन मैं ये चाहती हूँ कि at least आप लोग एक कि what is metabolic syndrome and what is pre-diabetes. आप लोग यहाँ से बस यही message ले जाएं तो that is very important. So this is my beloved institute. So there was a breaking news in BBC about during the COVID era that the poorest countries facing both obesity and malnutrition. यानी कि too much भी है हमारे पास और too less भी है, and I am afraid कि too less आजकल थोड़ा सा ज़्यादा है, but still there is a double burden of the disease, and several studies have been done and to see the affected population in Pakistan. And there was a very recent study in 2021 in which they have seen that in Pakistani girls, both in urban and rural areas, the obesity and the overweight is quite common. Almost 10 to 20% of the girls, young girls, are obese because most of the time they are sitting at home and not playing outside, so they are obese. So it was also said that there was a notable incidence of overestimation of underweight and underestimation of overweight and obesity. So हमारे पास obesity और overweight इतना रिपोर्ट नहीं हो रहा या उसको एक नॉर्म ले लिया जाता है, एंड दैट इज़ नॉट कंसिडर्ड कि ये इसके इश्यूज़ क्या हैं. सो दिस इज़ अ हाई टाइम कि हम इस पर कुछ तवज्जो दें. द हाइएस्ट इंसिडेंस ऑफ ओबेसिटी एंड ओवरवेट हैज़ बीन रिपोर्टेड इन केपी, which is almost 18 to 20%, followed by Balochistan. And lowest in Sindh, as we see, the Sindh is not in a good condition, it's 5.2%. More common over here is the malnutrition. And similarly, the overweight prevalence is also much more common in KP, followed by Balochistan, Punjab, and then of course, Sindh. This is a National Nutritional Survey 2018. You can see that the pointer that the overweight and obesity is almost 20%, and obesity is इसमें overweight इसमें markedly obese भी हैं और ये नहीं चल रहा. So this is the last figures I want you to concentrate on it कि ये हमारे पास 18 to 20% ये नहीं चल रहा है बेटा. 18 to 20% of the children are overweight, and obese are almost 10%. So we are going to have we are going to review metabolic syndrome and pre-diabetes. आ रहा है? नहीं, रहने दें आप, रहने दें, कोई बात नहीं. So what is metabolic syndrome? You will see this abbreviation MET-S, ये commonly metabolic syndrome के लिए use होती है. So it's a cluster of health condition. Basically, it starts from obesity, and then there are lots of things come with it. There is hypertension, there is insulin resistance, there is high triglyceride level, while low high density lipoprotein levels are there. So these are the basic things which you have to keep in your minds while dealing with the patients of. Again, this is the metabolic syndrome has been defined in several ways, but but it is said that it's a constellation of interconnected different disorders, which includes elevated triglycerides, altered glucose metabolism, reduced high density lipoprotein, elevated blood pressure, and of course obesity is the part and parcel. And last but not the least is the insulin resistance. So metabolic syndrome is associated and can lead to all these disorders in which there is type 2 diabetes, increased uric acid level, hepatic fatty liver disease, which is NAFLD, like non-alcoholic fatty liver disease, then PCOS and obstructive sleep apnea are the important associated issues with metabolic syndrome. So what about from where this term metabolic syndrome has come? So it started in 1920. In which Kylan has reported that there is an association of hypertension, hyperglycemia, and gout. And later on, several people were reporting this syndrome, but nobody has given it a term. So in 1992, insulin resistance syndrome was first was a term was given to this disorder in which there was hypertriglyceridemia, hypertension, and obesity. And finally, in 2001, the NCEP coined the term metabolic syndrome with the presence of 3 out of the 5 risk factors. I'm repeating it again and again that at least you should take this message that this is there in children also, as basically it is more reported in adults, but in children we are seeing these cases. There will be central obesity, there will be hyperglycemia, hypertriglyceridemia, high density lipoproteins are low, and there will be association of hypertension. So there are lots of in pathology factors, but it is said that obesity is a pro-inflammatory condition. If you do CRP, it will be little on the higher side in obesity. So there are lots of inflammatory markers which are involved in this due to hyperplasia, hypertrophy, and necrosis and macrophage infiltration in the adipose tissue mediates lots of inflammatory markers which eventually cause the endothelial damage, leading to hypertension and the cardiovascular disease and diabetes, predisposing to type 2 diabetes also. There is a new entity, reactive oxygen species, which causes all these changes and pro-inflammatory states leading to metabolic syndrome. This is a little bit of pathology. So finally, metabolic syndrome will lead to type 2 diabetes and cardiovascular diseases. What about the definition in children and adolescents? I'm afraid there are no, up till 2007, there were no definitions. So in 2007, IDF has made a consensus and defined metabolic syndrome in children and adolescents for the first time. There were different criteria in IDF they have proposed for the metabolic syndrome in children. Less than 6 years, like 6 to 10, there was no criteria, but however, 6 to 10 years of age, the obesity or the waist circumference would be more than 90th centile for that population and ethnicity. And the other parameters have not been decided in the age of 6 to 10 years. But in 10 to 16 years, the waist circumference would be more than 90th centile for that ethnic and the sex and the age group. And there will be high triglycerides level more than 150. There will be low HDL, like less than 40 milligram. And the blood pressure would be more than 130 systolic. इनमें से कोई भी एक हो सकता है. Either it is a systolic hypertension or diastolic hypertension. And last but not the least is the high blood sugar levels, 100 milligrams. So this is the basically definition or the criteria जिस पे metabolic syndrome you will start thinking and you will label the child as metabolic syndrome. While in the more than 16 years of old, there was almost similar criteria, except that it is the face circumference would be for that age and sex, and that would be the adult criteria. So finally, the IDF made a definition of metabolic syndrome for 10 to 16 years of age. अब इसमें waist circumference या basic obesity आ जाएगी, and number of any two of these anomalies. इनमें जितनी मैंने आपसे जिक्र किया, triglycerides, low HDL, hypertension, glucose, इनमें से अगर 2 भी होंगे, तो that would be counted as metabolic syndrome. So, बाकी और जो there are lots of definitions, but I prefer, and we all mostly see the IDF definition is जल्दी pick करती है. There are lots of advantages of IDF definition. So there are lots of issues in metabolic syndrome from head to toe. There are lots of issues. The fatigue and inability to focus, वो कहते हैं ना foggy brain हो जाते हैं. And even sometimes the children and the parents also come कि ये बच्चा कुछ down सा रहता है. The browning of the folds of skin and around the neck and the armpits, acanthosis, the famous acanthosis nigricans, high blood pressure, these are all present in the metabolic syndrome. This is usually in the adults, the body shape is apple shape and the pear shape is. And of course, don't forget the fatty liver. We are seeing the cases of fatty liver also in children. So this is the slide which I wanted to show. This is from the net. However, you can see the patients of acanthosis nigricans. जो बच्चा भी overweight आता है या even obese होता है, even overweight बच्चों में भी we are seeing literally an epidemic of acanthosis nigricans. ये blackening of the armpits, neck, and the behind the neck, we are seeing lots of cases. The skin tags is relatively common in the older age group. So again, the acanthosis nigricans is the hallmark of insulin resistance. जिसको भी insulin resistance होगी, there are lots of mechanism involved in the acanthosis nigricans that can occur in the metabolic syndrome. तो आपको early sign है पकड़ने के लिए कि yes, weight के बाद neck पे देख लें फौरन that acanthosis is there or not. So there are lots of things going on in the body and almost each and every part of the body is affected. How you are going to manage? This is the pyramid जो आपको obesity में भी नज़र आता है और आपको metabolic syndrome का भी यही pyramid famous है that health, diet and physical activity is the basic component and the main pillar, main main pillar of the treatment of metabolic syndrome. Then comes the lifestyle modification. There are lots of drugs, and of course the surgery. This is the same almost as morbid obesity, or there are lots of things which have been, again, this is from a pediatric guideline, that lifestyle intervention में सबसे पहले तो diet control है and physical activity है. Physical activity, vigorous physical activity, 60 minutes की at least 3 days in a week. And of course, in all of them, the physical activity and the lifestyle interventions are extremely important. Reduction of sodium, increasing the olive oil, increasing intake of fruits and vegetables, these are all a part and parcel of the treatment of metabolic syndrome. Then there are lots of drugs which can be offered according to the complication. For example, if there is hypertension, you can give antihypertensives, and if there are hypertriglyceridemia, you can give statins, and you need to start it. ये नहीं सोचना above 10 years you can start it now. There are recommendations of statins भी आप दे सकते हैं. You are not going to wait. Then last but not the least is the fatty liver disease, in which there are again lifestyle intervention. There is the role of probiotics, Lactobacillus reuteri and omega-3 fatty acids have got a very important role in fatty liver disease. So there are lots of drugs which have been, you can see the list, there are lots of drugs which have been offered. Metformin has been used off the label for the treatment of metabolic syndrome. So these are the drugs which are approved by FDA, जिसमें अभी आप लोग सुन रहे हैं, but again this should be done by a proper endocrinologist. From oral stat to semaglutide, you can start in the metabolic syndrome when the child is overweight and in the obesity, and coming in the obesity with the signs of metabolic syndrome. So these are relatively new drugs, semaglutide and liraglutide, but again they are costly and available in Pakistan. Oral stat has been given, but these are the efficacy. You can see that it is said that semaglutide is the most effective nowadays. So this is again the pillar कि lastly आपने क्या कराना है, surgery पे last option में जाना है. So I'm afraid this was a very bad sentence जो कि मैंने पढ़ा, but I was writing it, but God forbid, this is the first generation. अगर हमने ये Paul Zimmit, a very famous person in metabolic syndrome, he wrote this, that this is the first generation where I'm afraid children may die before their parents. So you have to control the obesity, and later on the metabolic syndrome is a complex phenotype. There is still a lack of consensus how to define metabolic syndrome, especially in the pediatric population. However, early identification and treatment of obese children can reduce the cardiometabolic disease, means hypertension and type 2 diabetes. Both the incidence can be reduced if we start looking for the things earlier. So an expert multidisciplinary team is required, but for you, my message is that at least try to pick it early, and then we can start the treatment. Few words about the pre-diabetes. Again, I'm afraid that there will be some figures. There was a breaking news after the IDF guidelines that 2021 Pakistan ranks 3rd in the prevalence of diabetes in the world. So we have to start thinking हमारे बच्चों को हमें बचाना है ताकि हमारी future generations type 2 diabetes में type 2 diabetics ना हो. So pre-diabetes is again a metabolic condition where blood glucose levels are upper threshold. And why it is important to diagnose pre-diabetes? Because the inflammatory thing will start beforehand, before the final like disease. जब diabetes होती है उस वक्त it is late आप कहते हैं. इस पर guidelines ने जो कि pediatric की जो book है जो guideline की हम use करते हैं for the diabetes and the pre-diabetes, they have given a very good definition that there are three things which are important that how to diagnose pre-diabetes. Number 1 is fasting plasma glucose. It should be above 100. Then you can say 100 to 26 के दरमियान होगा तो pre-diabetes होगा. When you do the 2 hours plasma glucose or OGTT, then the range would be 200. The cutoff would be 2. अगर आप यही याद रखते हैं ना, fasting plasma glucose 100 to 126. 126 पे तो diabetes हो जाती है, but 100 to 126 के दरमियान pre-diabetes है again. And finally, the HbA1c is 5.7 to 6.5 is the. ठीक है सर, बस ख़त्म कर रही हूँ. So there are lots of risk factors. There are some non-modifiable and some are modifiable, जो कि जो हम डिस्कस कर चुके हैं. I'm not going to, मैं सिर्फ अपना की मैसेज देना चाहूँगी कि आपको किसको स्क्रीन करना है. ये हमारे पाकिस्तान का प्री डायबिटीज़ का इंसिडेंस भी किसी से पीछे नहीं, ऑलमोस्ट 10% है. So home to screen children who are obese and overweight, and especially the obesity with BMI more than 95th percentile and overweight 85th to 95th percentile. और जिनकी family history हो उनको आपको screen ज़रूर करना है. तो again you can see that जिनको हमने screen करना है आपको as early as 10 years पर आपने screen शुरू कर देनी है, and screen every 3 years for pre-diabetes, especially if the family histories are there. My last message is that you please remember this healthy plate. और इस vegetables में potatoes और fries शामिल नहीं हैं. The whole grains, the fruits and the healthy proteins are there. And pre-diabetes trials are going on, but no metformin के अलावा कोई drug भी इतनी safe count नहीं की जाती pre-diabetes में. So it is high time that obesity and overweight is treated with due seriousness. Lifestyle intervention, pre-diabetes में भी metabolic syndrome में भी is the basic intervention and basic routine. The use of metformin in pre-diabetes is still being used, but better alternatives are still under trials. So we need multi-center trials. And मेरा ये पैगाम है जो 5 fruits and vegetables, 2 hours or less screen time, 1 hour of exercise, daily vigorous exercise, zero sugary drinks, no cold drink or juices, and of course 8 hours of minimal sleep. Thank you so much. Sorry for the thoda sa overtime.
Thank you very much. It has been obviously a very interesting topic, and it was very difficult for Mohsina to stop. So my time is over. I'm sorry, I would not be able to present because वो फिर free paper नहीं होंगे. Unfortunately, हमने देर से शुरू किया session, so I have like -2 minutes to speak and 50 slides to present. So I would not do that. कल एक स्लाइड थी जो हमने दिखाई थी इनॉग्रल में, आप में से कुछ लोग होंगे शायद. I'll just talk about that slide. कि non-communicable diseases is the new buzzword in the world. And I showed that about 41 million deaths are occurring across the globe due to NCDs. And that is 74% of all the deaths. जितनी भी अमवात हो रही हैं दुनिया में उसका 75% जो है वो non-communicable diseases है. And in the non-communicable diseases, people are talking about the big 4, and out of the big 4, like the cardiovascular and diabetes are directly linked to obesity. So we are really sitting on a situation where our children are heading for a major early deaths due to non-communicable diseases. I was going to, ये लगेगा क्या, इसको हटा ही दिया तुम लोगों ने, ये किधर गया ये? So I was actually going to talk about the genetics of obesity, but obviously we ran out of time. So I'll just show you 1 or 2 slides. एक तो ये etiology की slide है कि जिसके अंदर आपको एक spectrum दिखाया जा रहा है कि कितने types की obesity है. So we talk about syndromic obesity, then there is a genetic obesity, and then the polygenic that Mohsina talked about, and of course there are endocrine disorders. And I'll just show you 1 slide that will tell you all. Syndromic obesity आपको किताबों में मिल जाएगी, बहुत सारे syndromes हैं, Prader-Willi, Albright, etc. Lawrence Moon-Biddle, you know that. So I'll show you just 1 slide that will actually tell you all. We had this girl presented at NICH some years ago, which we could not wait. आप पूछेंगे 12 साल की बच्ची थी, इसका वजन कितना है? And this was the reason she was brought in an ambulance, sorry, not an ambulance, she was brought in an open car on a bed. She could not be placed on any chair. And this was her. And there was no way you can get her out of that car or ambulance or whatever you want to call it and weigh her down. And this was clearly not a simple obesity. So this was the genetic obesity. We did send the samples out and we found out that she and her brother, which was this one, had were leptin deficient. So this is the one last slide that I want to talk about. Okay, obviously the major bulk of obesity that we now see is your metabolic syndrome, your diet, and your other issues, that lack of physical activity, increase screen time, जो कुछ ये बातें अभी हुई हैं metabolic syndrome में. But there is a certain segment of obesity which goes far beyond that. So if you see a child with very early excessive weight gain, if you see a child with +4 standard deviation scores weight, especially with a family history of lots of consanguinity and maybe some early obesity in the family, then you have to think about various genetic causes. Of course, these are just lists. There are details of how they are acting, and leptin में क्या होता है और उसमें क्या होता है, POMC में क्या होता है, PC1 में क्या होता है, MC4R, but we can't go into that. So just think of genetic parts of obesity. When you see a very abnormal, morbid obesity, as we call it. Other than that, I think the first thing first is your common causes of obesity. You need to think about the endocrine causes. You need to think about the syndromes. You need to think about the metabolic disorders, metabolic syndrome, or the dietary obesity, as we simply call it. So I'll just stop here. Thank you very much for coming to the session. It's unfortunate that we started late. We have to finish with the free papers, otherwise we will not have time for the free papers.
थैंक यू डॉक्टर जमाल. कूजे में दरिया बंद करना ऐसे ही होता है, and you can do it very well. The reason why we are running fast is we want our young presenters to take the lead. उनका दौर है, उनका वक्त है. So as I announced early, the session chairs have a job to do. Of the 3 presenters, you have to decide who's the best, and that person would get the prize of young researcher. So we have 3 oral presentations. The first one is Dr. Fauzia Maiman from Aga Khan University. Her topic is association of individual and parental factors, relation to glycemic control in adolescents with type 1 diabetes.
So, Assalamu alaikum everyone, and thank you for introduction, Dr. Khadija. So, I am Fauzia Maiman. So, I am going to present my study. It is regarding the association of individual and parental factor in relation to glycemic control in adolescents with type 1 diabetes. We all know hyperglycemia is the major risk factor for the development of complication in diabetes. And HbA1c is the index of metabolic control, and it is a measure of long-term diabetic complications. And the reason for poor glycemic controls are numerous, like poor compliance to the diet, poor compliance to the treatment, and not adherence to the insulin regime. And also the family functioning and parental involvement in diabetic management are also strongly related to the glycemic control. And we all know the adolescent age group is difficult to handle because they want to take the charge of treatment, and the diabetic control is very difficult in adolescent age group. And so we decided to conduct a study on the adolescent age group. And in our setup, especially in the Pakistan, there is limited number of studies are available. to see the risk factors that are associated with poor glycemic control, specific in adolescent age group. So objective of this study was to determine the association of individual and parental factor on glycemic control in adolescent with type 1 diabetes at Tertiary Care Center, Karachi. So this was the study design. The cross-sectional study was done. We took 246 participants. HbA1c was taken done in last 3 months was taken. And we developed the structured pro forma that contained all demographic details, and including the risk factors associated with the individual, like compliance with the diet, compliance with the insulin, and the physical activity, and the number of clinic visit. Also, the pro forma contain the details about the parental involvement. And for analysis, we use descriptive statistic for the quantitative variable, and for qualitative variable, we use the mean and standard deviation, and chi-square test was performed to see the difference in proportion. So these are the results. We have total participants of 246. The mean age of is 13.7, and we divided this age group into the 2 subgroups, less than 14 years and the more than 14 years. Approximately the distribution was same. And this is the sex distribution. 56% was male and 44 female. Sorry, 56 was female and 44 was male. And you can see the results were alarming. Only 20% of adolescent population has a very good control with HbA1c of less than 7.5, and more than 80%, about 80% has a HbA1c level of more than 7.5%. Then we saw the different glycemic control in different age group. The result is same in both age group. The control was poor. In relation to the gender, the female tends to have more poor control as compared to the male. So this is the chart. We didn't find any relation of glycemic control in relation to the gender, duration of diabetes, and household incomes, but there is significant relation in different subgroups. And also we found the significant relationship of poor dietary compliance with the glycemic control. As the dietary compliance is good, the control will be good. And also there was a significant association of compliance with number of injection with the glycemic control. We usually, in AQ, we usually use multiple dose injection. More than 95% of patients are using MDI or basal bolus regime. And you can see there is, as the patient is not compliant to the insulin injection, the control is poor. And also the number of clinic visit. We usually recommend at least 4 visits per year in clinic. As the patient is not doing regular follow-up, you can see the glycemic control is poor with significant p-value. And in the last, the parental adherence is also important. You can see if the parents are not adhere or not involved in the control of diabetes, there is chances of poor glycemic control. So in conclusion, our study revealed the poor compliance with diet, insulin injection, infrequent follow-up, and less parental involvement were all associated with poor glycemic control. So we recommend that this glycemic control can be improved by improving dietary compliance, intensive insulin therapy, and by ensuring regular follow-up. And in the last, also parental involvement in children diabetes management significantly impact good glycemic control. Thank you.
है या नहीं, क्वेश्चंस है नहीं है?
We can have just 2 questions.
अच्छा, why, I mean, what were you planning in this study? I mean, obviously कि अगर compliant नहीं है patient, उसका follow up नहीं है, parents follow नहीं कर रहे आपकी advice को, तो you expect the control to be poor. So, were you trying to document anything different?
Sir, this is very, very good question. Sir, at least we should focus on, sir, these are the social factors. At least जो हम improve कर सकते हैं, we are now focusing our management towards that. So after this study, we have introduced the carb counting, and also with every visit, we ensure the education, dietary education regarding the management of the insulin would be revised. हम
कार्ब काउंटिंग तो एक स्टेप और मुश्किल कर रहे हो, वो पेशेंट पहले ही कंप्लाइंट नहीं है, उसको कार्ब काउंटिंग सिखाओगे तो वो तो बिल्कुल ही गायब हो जाएगा।
नाउ वी आर मूविंग टुवर्ड द कार्ब काउंटिंग, और हमने देखा है अंडरस्टैंडिंग इज वेरी गुड, और हम उसी पेशेंट में इंट्रोड्यूस करते हैं जिसमें हम देखते हैं कि अंडरस्टैंडिंग इज गुड।
जी डॉक्टर आ रही है।
Education of our parents. So after this strategy, we identified all factor was there. Parents' low education is also a factor for poor compliance, and the understanding of this and distance cover. This is the also was there.
Yes.
So here we have done the at that time identified the factor that we should have a nutritionist at our institute when the child used to visit for gaining insulin. So they should be educated with respect to diabetes as well for the nutritional factors. So that we can improve the factors that we identified.
Okay, thank you for sharing.
Very rightly said, and I think the speaker was also trying to say that they tried to start a nutritional intervention after this. So next presenter is Dr. Myra Riaz from NICH. She's going to present monogenic diabetes in Pakistan in infants and children. Are we different?
Thank you very much, Dr. Khadija. I am going to present a very interesting presentation. Presentation start करना। किस नाम से? Myra. So I'm going to present a very interesting and unique data from National Institute of Child Health about monogenic diabetes. As the name suggests, monogenic diabetes is a type of diabetes resulted from a single gene defect that can be spontaneous mutation de novo, or it can be autosomal recessive or autosomal dominant. Up till now, around 40 mutations have been identified with their characteristic typical phenotypic features. This is a chart depicting the difference in monogenic and other commoner forms of the diabetes. Here we can see that it is different from other forms of diabetes in the form of its pathogenicity, clinical features, absence of autoimmunity, and family history of diabetes in majority of the cases. There is a long list of responsible genes which are responsible for its pathophysiology of monogenic diabetes and neonatal diabetes in pediatrics. And why it is important to detect these genes? Because it gives us the clinical precision where we can stop the treatment in GCK, and we can switch safely patients from insulin to sulfonylureas in few mutations like ABCC8 and KCNJ11 mutations. So it is always good to send the genetic samples if you are suspecting a monogenic child, diabetes with a monogenic pathophysiology. As we all know that higher rate of consanguineous marriages and intratribal marriages we encounter in Pakistan, we encounter a genetic pattern that is quite different from other parts of the world. And currently we are sending the samples to Exeter, England University. Why to do this study? Because we wanted our patients to know and predict their expected clinical course. We want to offer them genetic counseling, and we want to register them for antenatal screening as well. So our objectives of our study was not only to detect our genetic pattern in our patients with diabetes, but also to compare it from other parts of the world, other nations like Arabs, Turkish, and British. We included all those patients who presented to us in the neonatal period with diabetes. We included those patients as well who presented in 6 months to 12 months of age with their islet cell antibody profile negative. And we included older patients who have extra pancreatic features like liver involvement and skeletal dysplasias, as well as visual or auditory deficiencies. After inclusion, we tried to send their samples to Exeter. Initially, they did the common mutations, which are commonest for neonatal diabetes and monogenic diabetes, and if they are found to be negative, they send the customized targeted next generation assay according to the typical phenotypic features of those patients according to their protocol. Around 1,000 patients are registered in our endocrine clinic with diabetes. Out of them, 39 were suspected to have monogenic, and we sent their genetic samples. We did not see any gender predilection. All male and female were equally exposed. And we have higher rate of consanguinity, as I have already told. Around 27 patients were of neonatal diabetes, and 12 were suspected to have extra pancreatic features. Among those 27 who were suspected to have neonatal diabetes, the commonest gene found was for Walcott-Rallison syndrome, that is diabetes with skeletal dysplasias, followed by the channelopathies, which include KCNJ11 mutation and ABCC8 mutation, and then we have glucokinase mutation and insulin gene mutation, 2 each. We had 1 patient of Fanconi-Bickel syndrome, and we did not find any mutation in 9 patients out of these 39, though they were suspected strongly to have monogenic or neonatal diabetes. This is the diagram which depicts the same results which I have already mentioned. Among syndromic diabetes, we had almost 100% positivity results. Like we had among 12 patients, 6 were positive for Wolfram syndrome, which is also known as DIDMOD, includes blindness and deafness along with diabetes and diabetes insipidus, followed by thiamine responsive megaloblastic anemia, also called Rogers syndrome. 3 patients were diagnosed to have TRMA in our cohort, and 3 patients of 2 families have found to have H syndrome, which is the constellation of symptoms like hypogonadism, hypertrichosis, along with monogenic diabetes. This is a pie diagram depicting that 50% of our patients from syndromic diabetes had Wolfram syndrome, also called DIDMOD, and 25% each for TRMA and H syndrome. The results of our study. Then we compared our results with different other nations like Arabs, British, and Turkish. Here we can see that our results are quite similar with the Arabs population, maybe because of the similar higher rates of consanguinity in both groups. As well as here we can see that the most prevalent gene found for in Arabs population was similar to R, as Walcott-Rallison was the commonest prevalent gene found for neonatal diabetes in Arabs and in Pakistani children as well. Whereas here in British population, we can see that it is the most, the KCNJ11 is the most prevalent gene, and in Turkish we observe that GCK mutation was the commonest found. The other striking features in our population, we had that all the suspected cases of syndromic diabetes have positive results of genetics. Like in Wolfram syndrome, we found 6 patients of Wolfram and 3 patients of TRMA, and 3 patients of H syndrome, which were not the case in other nations of the world. Pakistani versus Arab children, here we can see the consanguinity is high in both, and the commonest gene found was EIFK2, that is responsible for Wolcott-Rallison syndrome. Pakistan versus Turkish population, here we can see that the commonest gene found was GCK, where we had only 2 patients of GCK found. Pakistan versus British, where we can see that KCNJ1 was the commonest mutation found, and the consanguinity was least in them. These are a clan of our patient who were diagnosed under 5 years of age. They were said to have Wolfram syndrome, and all of them were having visual problems and deafness. Then we have, this is, yes ma'am, I'm just finishing. This child is, was transfusion dependent, but now on just replacing thiamine, he is now off transfusion. So my conclusion is that monogenic diabetes is not very common. It almost 4% occurs, and can give 75% of time we can get genetic diagnosis in monogenic diabetes. And we can offer insulin, we can offer oral hypoglycemics to few of the mutations like ATP channel mutations. So we had to develop our own genetic system at the national level. Thank you very much.
The questions towards the end. Now I invite the final presenter, Dr. Fariha Kausar from Children's Hospital, Lahore. Her talk is about role of capillary blood ketone assay in management of DK in pediatric ICU.
Bismillahirrahmanirrahim. I'm Dr. Fariha Kausar. I'm a fellow in pediatric critical care medicine at Children's Hospital, Lahore. And my topic is role of capillary blood ketone assay in management of diabetic ketoacidosis in pediatric intensive care unit. As we all know that children presents as an acute, DK presents in children as an acute life-threatening emergency, and around 30% of pediatric patients, they present with DK at diagnosis, while others may develop during the course of their illness. And the incidence of DK has increased from 1.8% in 2010 to 3.4% in 2015. And with the advancing technology, we know that the focus of DK management has changed from being glucose-centered to ketone-centered. And the major predominant ketone body in DK is beta-hydroxybutyrate. And the ketone meters available in market, they test this predominant ketone body. So, and we all know that urinary ketones measurement is relatively cheap, but it has its limitations. And we have undertaken this study as the data was lacking regarding its use in DK management in PICUs. And it is going to be the second study from the low resource settings. And previously, the first study was published from Indus Karachi, and this would be the second study. And we done this study with the objective to assess the clinical and statistical correlation between the capillary ketone assay and the standard acidosis markers. It's an observational study done prospectively at PICU Children's Hospital, Lahore, over a period of 6 months from July to December 2021. All DK patients got enrolled with either gender and the age ranging from 1 month to 16 years. And those who left against the medical advice got excluded from the study. A sample was collected using non-probability sampling technique. 55 patients got enrolled, and they were managed with the standard DK protocol with IV fluids and regular insulin. And serial assessments were done, clinical as well as labs. Initially, the capillary ketone assay was assessed at the bedside on admission, and then 4 to 6 hourly. And the blood glucose was measured early at the bedside. Serum electrolytes, creatinine, and blood gas were done 4 to 6 hourly. Data was analyzed using SPSS 25, and the qualitative variables were measured as frequency in percentages, quantitative variables as mean and standard deviation, and Pearson correlation coefficient was applied at 2 points, on admission and at the resolution of DK. P-value less than 0.05 was considered significant. So coming to the results, there were 55 patients, and the mean age was 8.2 plus minus 3.5 years. And there was slight female predominance of 50.9%, and the newly diagnosed cases were 60%. And we had a major portion of moderate to severe decay, and the moderate decay 23.6% and severe 74.5% were reported in our study. Coming to the metabolic characteristics, the standard acidosis markers, which included pH, bicarb, ANN-GAP, and base deficit, the children on presentation were acidotic with high ANN-GAP, and the capillary ketone assay, measured by the ketometer, it was in the range of 6.36 millimoles per liter with a range of 3.5 to 8. And these are the glucose values and the metabolic changes. And on resolution, the capillary blood ketone was 1.41 with a range of 0.6 to 2.80. And regarding chloride, I want to mention that we noticed hyperchloremia in 43% patients. And our 12 patients had AKI as well, based on creatinine values using KDIGO criteria. So after applying the Pearson coefficient correlation, what we noticed that there was a strong statistical correlation between the blood ketone assay and the standard acidosis markers on admission. But there was no correlation found between the blood ketone assay and the parameters on resolution. This marked variability is due to the factors that the ketosis resolved earlier, and the acidosis marker, there was still persistent acidosis, and we found out that there are other causes of acidosis like hyperchloremia, acute kidney injury, and lactic acidosis. That's why we didn't find any significant correlation on resolution. So with the help of this study, we concluded that capillary ketone assay has significant role in decay management. It helps in prompt diagnosis. As we know that urinary ketones has its limitations, and our 2 patients had less than 1 ketones at diagnosis, but the values were high on ketometer, so they were promptly diagnosed and managed. So this helps us in leading early initiation of treatment as well. We can early discontinue the insulin infusion at the resolution of ketosis without waiting for the blood gas parameters to normalize. And secondly, it helps us in identification of the other causes of metabolic acidosis in such patients. Just like at the end of at resolution, there were the other associated causes. So with this, we concluded the capillary ketone testing is simple, inexpensive point-of-care test. Its use should be encouraged in PICUs, especially of low resource settings, because of its cost effectiveness. And also, it can reduce our length of stay as well by prompt diagnosis, early initiation of therapy, and early discontinuation. And it can reduce the length of stay in our PICUs. So this should be encouraged as well. So thank you, that's it.
I really appreciate your sticking to the time schedule. Excellent presentation. If there are no questions.
Yes, sir, I want to show. Sorry, this is the ketone meter we used from Econ Laboratories, USA, and we are very thankful to Dr. Anwar Haq for introducing this ketometer in our setup as well. And this would be the second study from low resource settings. Keto strips available hai. The company provides us with the keto sticks as well. So we Karachi se hi hame milti hain, and we have to wait for the keto sticks as well. अब वो आ गई थी दोबारा. We just ordered and they say कि normal level? Okay. Basically, blood ketones in body, its normal level should be less than 0.6 millimoles per liter. So we took the level of more than 3 millimoles per liter diagnostic for diabetic ketoacidosis. For more than 3 tha, so they were taken as diabetic patients. So normal level should be less than 0.6 in the body.
Ji.
Yes. Yes, good. That's good. Yes, urinary ketone, that presentation, that's why we... Yes, in two patients only, they were less than one, but the whole scenario, clinical picture, hyperglycemia, severe acidosis, and the ketometer showed a high ketone level. So we managed that patient as diabetic ketoacidosis because usually urinary ketone has limitations. In severe dehydration, you cannot get adequate ketone levels. Urine output कम हो जाता है, that's why nil भी आ सकते हैं urinary ketone. So it's a very two on, at the time of diagnosis, only two patients, two patients में urinary ketones were less than 1. They were not large ketones. So due to the whole clinical picture and the ketometer availability with us and high ketone levels, we managed that patient as diabetic ketoacidosis, and alhamdulillah, he survived. So, okay, thank you so much.
What about at the recovery?
We'll have to stop the questions. You can discuss that over the tea. And may I request our esteemed chairs and co-chairs of the session to announce. May I ask the mic to be taken to the chair for them to announce? इसको बंद कर दें. Thank you, Dr. Mumtaz.
First of all, I would like to say all papers were excellent. Okay, क्योंकि आप लोग छोटे बच्चे हो अभी हमारे लिए, and you are just starting your thing. So I think first presenter ने भी बड़ा अच्छा present, very scientific था उसका, you know. उसके बाद second जो presented था उसमें भी हमें काफ़ी knowledge मिली, and it was also a very scientific paper. लेकिन आपको पता है जजमेंट करना ज़रा मुश्किल होता है, और हम एक को ही हमें कहा गया है कि अवार्ड देना है. तो जब हमने कम्युनिकेशन स्टाइल, साइंटिफिक आस्पेक्ट, क्लिनिकल डिलीवरी एज वेल एज कुछ सीखने को और मैसेजेस जो क्लियर थे, तो हमें लगा कि डॉक्टर फरिया कौसर का जो था वो बेस्ट पेपर था. एंड इंटरेस्टिंगली वी ऑल थ्री एग्रीड, ओके, कि यू नो शी इज़ द विनर. बट दूसरों ने, मायरा और फौजिया, you people also did a good job, but when there is a competition, क्रिकेट में भी ऐसा होता है ना, किसी की हार, लेकिन nobody has lost. I think that आपका बहुत अच्छा पेपर था, and we would like you, encourage you to continue to make presentations, and it becomes better and better. So thank you very much. Okay. आ जाएं ज़ीनत, आ जाएं आप.
Maybe we can take her down and Dr. Zenith can give it over there. You वहाँ पे आ जाएगी.
Please, panelists.
May I request Dr. Jamal to present?
Please. Hello. Ji, there are shields for the panelists.
So may I request Dr. Jamal to present the shields to our esteemed chairs and co-chairs. Madam Zeenat Isani. नहीं ऐसा होता नहीं है किसी भी साइंटिफिक तरीके बाद में Dr. Mumtaz Lakhani, please. And Dr. Khemchand, please. And then there are also shields for the speakers. So Dr. Jamal को Dr. Madam Zeenat के हाथ से मैडम को बैठे रहने दें, डॉक्टर जमाल वहाँ आ जाएंगे. वो अभी करवाती हूँ. So thank you. Thank you, Dr. Jamal. Dr. Mohsena Ibrahim. And I'll be also taking a shield from